Well, good morning. Thank you all for making it this early in the day. We're really excited to have the 8th annual Health Law Year in Review Year in Preview and for you to join us. So a couple of logistical things before we start. First of all, I'm Glenn Cohen. I'm the faculty director for the Petrie-Flom Center and a professor here at the law school. I want to thank a bunch of members of my team, Caitlin and Chrissy, who you've probably met, and Carmel, who's been enjoying a great maternity leave, but decided to come by today, not in an employment capacity, but as a visitor and attendee capacity. But she'll be an honored guest, but she'll be happily back with us in January. A couple more logistical announcements. We are, some would say, fanatical about keeping things on time, and we will do our best to do that. In order to do that, for many of the panels, we'll be using my friend, the 1980s Stranger Things featured limit timer device. This is a device that has a red, yellow, and green light, and that is so the speaker and you can know whether the speaker is within time, getting a little close, or over time. When speakers go over time, I don't think you have to stand up and yell, "You're over time!" But I do encourage you nonetheless to kind of look a little uncomfortable, maybe fidget a bit, some social ostracization. It's really good for keeping people on time. And that includes me too, since I'm moderating this particular panel. A couple more logistical announcements. First of all, the bathrooms are down the hallway to the right. Turns out to be an important thing to know. This is a public building and a public space, so please keep an eye on your valuables. Don't leave them for too long. Maybe the last thing to say is that we have a hashtag if you are Twitter-centric, and that is hashtag Health Law Preview. Hashtag Health Law Preview, one word. And of course, our Twitter presence is at Petrie-Flom, at Petrie-Flom. Okay. Well, I think we should get started. I'm going to introduce the first panel, which I'm also moderating. This is going to be a panel on challenges facing healthcare general counsels. And we're going to be joined by Catherine O'Rourke, who's the Chief Legal and Compliance Officer at Smith & Nephew, and Andy Fuqua, who is the Senior Vice President and General Counsel at Cambridge Health Alliance. I've got a series of questions I'm going to ask them, but we'll also leave 10 minutes towards the end for questions from you, the audience. All of the panels will have some time for the audience members to ask questions. And just to tell you a little bit about how that's going to work, we have a microphone set up right here. People who want to ask questions will queue up. Questions ought to actually be questions. That means within the first 25 words, if there's not a question mark in it, it is not a question, and I will probably say to you, that is not a question. What is your question? Just so you know. Okay, well, with that said, please give a big round of applause to our first panel. So as we start, do you two want to say a little bit about your current roles, and then we'll talk to the questions? Go ahead.
Sure. So I'm the Chief Legal and Compliance Officer at Smith & Nephew. We're a global medical device company. We have orthopedics products, sports medicine products, and advanced wound care products. In my role, I have a global team around the world of lawyers and compliance professionals.
And I'm the General Counsel for Cambridge Health Alliance, whose headquarters are 3/4 of a mile up the road. We're a licensed safety net hospital, but I think the best way to describe us is as a healthcare organization that provides first and foremost primary care services to safety net populations and all populations for that matter, and secondary community level hospital services. And in particular, we have a huge presence providing both outpatient and inpatient mental health services. And I'd also, the life of the general counsel isn't necessarily always very sexy, and we do a lot of Kathy and I were talking about how we often do a lot of very mundane tasks. So I want to thank the Petrie-Flom Center for convening this session and other sessions for general counsels, because it really gives us an opportunity to stretch our minds and really try to flex our legal chops in a differently and forward-thinking and challenging manner.
We're really glad to have you as part of the community. So I want to start by asking about the year that was 2019. What do you think the biggest challenges facing yourselves, but healthcare general counsels in general were? And I'm curious whether you think that if we were to take a larger poll of general counsels across all fields, whether they would be similar or different, or were their challenges very healthcare specific?
Sure. So I can start. So it's the time of year when we are working on our annual report at Smith & Nephew. We're a publicly traded company with listings in the UK and the US. So I happen to be working on our enterprise risk management section just recently. So this question was very well timed. And I think one of our principal risks that was very clear in 2019 is sort of political and economic uncertainty and how that impacts our business, and I think probably most businesses, but also healthcare in particular. So a couple of examples, for instance, navigating the situation with the tariffs. We manufacture products all over the world, and we try to deliver those medical products all over the world. So we manufacture some products in China that we like to have available on the US market, and how the tariffs change and whether we fit in any of the exceptions was an issue this year. Similarly, Brexit and the changing medical device regulations in the EU and how those two things work together in terms of making product available on the EU market. And then sort of more probably closer to home to healthcare specific, as we change, I think, to value-based healthcare solutions, trying to navigate the anti-kickback statute in a way that we can deliver real solutions that help patients and healthcare organizations save money, but make sure that we do it in a way that's consistent with existing laws that were written at a time that really they're not really fit for purpose. But there has been an effort this year at the OIG to try to reform some of the safe harbors, so participating in that dialogue has been really important in 2019.
Kathy, we didn't plan this, but that's, I think, a great segue. I was thinking about this as I was driving down back from Thanksgiving. I was on the highway, and there was the regular flow of traffic, chortling along at 70 miles an hour. Then there were the hot rodders zipping through us at 95. And then occasionally there'd be that random person going 50 in the left-hand lane. And that is, I think, a lot where is a great metaphor for the law and healthcare right now. The overarching challenge, say as we shift towards value-based care, is that the law is that person driving 50 miles an hour, and the anti-kickback statute and the safe harbors don't really match up with the push by another arm of the government, Medicare, to push us, and the industry to push us towards value-based purchasing. So there's that real tension is an ongoing tension that we face. And in fact, one of your competitors, I saw, was looking at a proposal from a medical device manufacturer, and I thought that's just a little too creative the other week. I think the big challenge that we're certainly facing, and I think all hospitals are facing, or the big development, is the uncertainty in the future. On the one hand, there's Medicare for all, the talk about Medicare for all. We're a safety net provider, and so therefore we depend greatly on Medicaid funding, either in the straight fee-for-service or through other mechanisms available through the Massachusetts state Medicaid waiver. And now we're seeing movements and attempted policy changes from CMS seeking to limit or constrain or restructure Medicaid. And so there's the pull for Medicare for all, potentially on one hand, and then there's the push for Medicaid for none. And how does the organization navigate that situation? It's very challenging and difficult.
Interesting new slogan, Medicaid. I'm not for Medicare for all, I'm for Medicaid for none, right?
Well, that's it. Based on recent publications in the Federal Register, it seems to be the case.
And speaking of the Federal Register, just to go a little deeper in something you said, Catherine, I'm curious whether you feel you have an HHS that is more receptive than ever to changes to the anti-kickback, or whether you think this will be an exercise that everybody will have put forward ideas, but not really going to culminate in a big change.
No, it's interesting. I do think that it seems as though this administration is more receptive. But the challenge, of course, is that the turnover in the administration and the just chaos in Washington generally works against that. So we requested an advisory opinion on a value-based care initiative that took 2 years to get a letter. We did eventually get a favorable letter, and it was not particularly cutting edge, I don't think, but it was, I think, really in the best interest of patients and fit squarely within value-based care reimbursement. And there is a lot of discussion right now over around the proposals, but whether they can actually advance in the current environment. Right now, for instance, the medical device tax has been suspended, but if nothing happens, it will go into effect on January 1st. And what we're hearing is that right now, although there's bipartisan support for suspending it again, nothing really is getting done in Washington that doesn't relate to the impeachment proceedings. So
I can understand that, given how we're glued to our TVs every
Right.
day. I'm curious about how you're planning for the next big thing that hasn't materialized yet. So, you have budgets, as do all of us. But I'm curious, if you had money sitting around that you could put to get someone to research a new issue that you're not dealing with yet, but you're worried about. What would be the kinds of issues that are kind of the most interesting for you or the most pressing for you to get more help on?
So thinking of new issues, there's the ongoing litany of issues, but I'm very intrigued right now as we look at new models and deliveries of care in the integrated care setting. And in particular, I have charged one of my team. I said, you are going to become the telehealth expert. I would love to just dedicate an army of highly paid outside lawyers to educate us. That won't happen, of course, so poor old Andrea will become the telehealth expert. In addition, the area of algorithmic medicine. In a community hospital setting, we're not necessarily doing a lot of the super highly technical procedures, but the notion of artificial intelligence or algorithmic medicine will be creeping into potentially areas such as radiology. Do we trust an algorithm or a computer to read a scan as opposed to a radiologist? Otherwise, we're already beginning to see some algorithmic medicine. For example, in behavioral health, or all healthcare, we do a lot of screening, particularly for various mental health conditions such as depression, anxiety, and the like. And we're seeing out there that instead of administering, say, 100 questions tool to each patient, that there are algorithms out there that will shorten that process by asking follow-up questions based on how an individual responds to a prior questions. We think that's a great advancement, but to what extent, the question we have is, can we rely on such tools? I think it's patently clear, the questions at least are clear when you're saying, do we trust a software system to read an MRI scan as opposed to a radiologist or some combination of the two? But I think there are questions in reaching initial diagnoses for mental health conditions. How are we going to be using that tool? And that I think will be a real challenge as the law seeks to define the standard of care.
What would you like to spend your money on?
Yes.
It's fictitious money, I'll give it to you right now. Go ahead.
Exactly. Yeah. Could you talk to my CFO? I think sort of, again, building on Andy's answer, very much similar space, how the privacy legislation that's kind of changing rapidly will apply. I think right now, in particular for us, there's so our R&D teams are so interested in the power of data and how we can use that to innovate. But how do we do that in a way that complies with privacy laws? Do our current privacy laws really allow for the innovation that we need? Obviously, we're all very sensitive to patient healthcare data, but where's the right balance between the law and innovation and actually the ability for healthcare professionals to share information to treat a patient? And so I think for me, if I had an unlimited budget, I'd be putting a lot of it towards privacy right now.
That's exactly where I was going to go next. So to ask you a little bit about your experience with some of the changing landscapes. So we have, on the one hand, HIPAA, some interest in potentially revisiting in the United States, but more importantly, I think we have GDPR, the General Data Protection Regulation, Europe, really coming online right now. And then we have California going to come online pretty soon. And I'm curious for each of you how much of these are kind of part of your day-to-day life of planning, how you feel about the different regimes, whether you think you're going to kind of try to basically comply with the most demanding, even if you don't have to everywhere, because the idea of having your devices sometimes under one, sometimes under the other is kind of impossible to imagine. Or just say a little bit of how you're dealing with these changes in privacy law.
Do you want to start, I think?
Yeah.
Sure, I can start.
You
For me, it's every week because I have a team in the UK. It's actually where our primary listing is. So GDPR is very much part of my day to day. So so first, in terms of just privacy, making sure that we are doing, I think at this point, what it has to be, frankly, for a global organization is best efforts, because in China, they are literally changing the privacy law every day, trying to navigate that landscape. Europe, you've got different regimes. Add Brexit into the mix, and then of course we have HIPAA here. So for us, I think what I am trying to build is a real recognition that sensitive information, we need to protect at all costs, and we have to have best efforts in place. But at the same time, as I said, I really feel strongly about making sure that we don't stifle innovation in the process, making sure that we actually think about patients' best interests first. And even as a patient myself, sometimes navigating privacy within various hospital systems, I feel the frustration myself, but at the same time, I obviously certainly would never want my healthcare information available to anyone. So I think as a patient, you live it day to day. As somebody who's involved in trying to innovate for the best interest of patients, you're trying to find that right balance of compliance with important law, but also making sure you don't stifle innovation in the process.
Where to pick up? I think the GDPR. I was at a Petrie-Flom session, I think, of GC Roundtable, and they were talking about the group was talking about the GDPR. I was just sitting back thinking, well, I don't really care. I'm a local safety net healthcare organization. What do I care? Then lo and behold, it turns out we have a research function, and lo and behold, all of a sudden, one of our research groups wanted to use some data in collaboration with a European group. So GDPR will be reaching, across the entire world. In that case, I called a specialist and said, please tell me what to do. But, the bigger concern I have with some of the privacy laws is how do they fit in with the integrated care? How do you balance the tension between ensuring that you are providing patients integrated care within a particular system or more globally? And this is becoming a particular concern because either third-party payers, and in particular Medicaid or Mass Health in Massachusetts, is placing a focus on social determinants of care and requiring that healthcare providers partner with other community resources to address these social determinants of care. So how is it that you navigate and determine when may one of these third parties have access to a patient's information? I, for one, would say, HIPAA does present a series of hurdles in that area, and I'm thankful for them because it forces us to stop and think and be very careful and thoughtful about how information is shared and whether information is shared. For me, I'm comfortable with the constraints of HIPAA, but I do recognize there's another tension in the area of research. In terms of California, I don't think that the California law itself will impact what I do on a day-to-day basis, but call me a Hamiltonian, but I am worried about having multiple conflicting regimes within the U.S. I would prefer some degree of certainty, and if California adopts a standard, then will Massachusetts adopt a standard, and then how in the world do we navigate that?
Wonderful. Want to touch a little bit on artificial intelligence, which both of you already mentioned. And I'm curious both in the today world, but also in what you're planning for 5 years from now, whether you think it's mostly hope and hype, or whether you think there's actually some real changes to your business models, to your day-to-day practices that are coming. So, there is this thing known as the hype cycle where you climb up to the peak of inflated expectations, only to drop down to the trough of disillusionment. And at that point, that's when you actually make progress. And there's some people who think, well, we're at the peak now, we're on our way up the roller coaster. Others who think that we're actually further than that. And I'm curious what your own kind of temperature is on these developments and how much of a change it's going to make in your day-to-day practice.
So I think for us, we absolutely, it's not, so artificial intelligence is really for us more of a pipeline issue. It's not a today issue, but I think that robotic assisted surgery is very much a reality today. And the question is, what will surgery look like 5-10 years from now? I do think artificial intelligence will play a role in that. And so I think I absolutely think that will be the reality in the future. I don't know if it'll be 5 years, but I think that there will be an aspect of artificial intelligence that will, I think, improve our access to surgery and some of our surgical techniques.
I tend to think we're still on the hype climb, and it will be very interesting. So I'm not worried about it for the immediate term, except as I had mentioned earlier about some of the particular early applications right now. I think the real question, one of the tensions I foresee, though, is who is practicing the medicine? There's going to be a real question there. Is it the physician practicing medicine, or is it Google Health practicing the medicine? I think that's going to be a real tension coming forward. My guess is that all the hype people are saying, well, these AI systems will be able to perform any number of medical and or diagnostic tests and procedures, obviating the need for very expensive healthcare organizations and providers. I think that's that's proof that we're still on the hype curve. I think the reality will be that 5 years from now, we'll see physicians and other practitioners on care teams using tools, but merely using AI as an additive tool or a helpful tool.
And Andy, you may feel like this is not something you should get into, but let me ask anyways, and you can tell me, let's talk about that another day, very politely.
Well, it depends. One of my trustees just walked in the room.
Okay, well, in that case, you should definitely have to answer the question. There's been a lot of stories recently, and this plugs in both what we talked about with HIPAA with the artificial intelligence conversation. In particular, Google has had a number of stories about their deals with hospitals, Ascension Health, and before that, the University of Chicago, relating to patient data. And we see a little bit of a, I don't know, I wouldn't call it a race, but certainly an attempt to build up stores of electronic health records and partnerships. And I'm curious, not to talk about your experience with that, but what you think the sensitivities are here. And if you could meet a fellow young general counsel who said, I've been approached on something like this, what kind of advice you would give that person in thinking about these issues?
Wow, we are in a law school. So my first piece of advice would be tread very, very lightly on this. Remember that we have a duty and an obligation to our patients to protect the privacy of their medical records. There are certain forms of limited data, called limited data sets, that we can share. And I think, if that is the nature of the discussion and you're talking about raw, unattributed data that cannot be tied back to individual patients, go for it. That's a hugely important value, not only to manufacturers such as Smith & Nephew, but generally to the healthcare community as a whole. But if you're talking about a system whereby we're sharing actual patients' records and putting them into a massive database, do not go there, period.
Great. Catherine, from your perspective as somebody who might want access to some of this data or partners and stuff like that, I'm curious whether you have any general advice, not about any specific business practice, but any general kind of views about these stories that are coming up and how you think they're affecting the industry.
I think, generally, I think it's a topic that comes up pretty much every week in the manufacturers, probably at every manufacturer, about how can we harness data to improve products and how can we do it safely. And I think the real question is what does it, there's a lot of, I think, especially when you're dealing with non-lawyers about what really is de-identified data, especially even when going back to our privacy discussion, there's different standards by country, possibly soon by state, about what it really means to have de-identified data. So for me, that's the big issue is, as Andy said, there's so much value in truly de-identified data, but what really constitutes that and how do we really make sure? And then when you add cyber risk on top of it, if you get that basic thing wrong, it can be catastrophic. So,
great.
That sort of ties into combining the two questions. A discussion that I was having yesterday, and it's regarding various applications and tools that we can use with our patients. Or either for communicating with them directly, or third-party devices that can either alert patients about upcoming procedures, or out there in the market there are tools where apparently for a limited subset of substance use disorder patients. A reward of some sort is apparently clinically very helpful. But then the question is, where is data or information residing? Who owns that data? Do you need to have the patient consent to having that data provided to a third party? Can you merely do it by saying this party's a business associate agreement, is a business associate, and thereby we can bind them contractually? And it was a very much a law school type discussion because we were running through any number of hypotheticals about who might own the data, who might be generating the data. And then if it's going from one party to another, or you have to ask the question, is it going from one party to another? What does the patient know about that? And has the patient agreed to that? So that's it's a spider web. It's a spider web, and it's really fascinating.
So let me push you on to a topic that's much more certain and much lower stakes, which is the election that's coming up. Do you have views about the ways in which, in the Democratic primary in particular, to start there, the various proposals that are being discussed at the moment in healthcare? First of all, the attention to healthcare, especially in the early phase of the primary, has been very interesting. But do you have views about the way the various proposals will change the way you live your life and the way your business lives its life if they were to go into effect, or just general reactions to the discourse thus far?
Okay, I guess I get to start. No, not really, to be quite honest, but the reason I say that is we really don't know what is going to come to fruition. And so will candidate espousing Medicare for all be elected, and then will that candidate be able to actually implement Medicare for all, or will it be some lesser version, some intermediate version of that? We simply don't know. I think what it's telling me, though, is as we look at the world today, we can't get locked into and assume that the way the world is today is the paradigm for how it will be 5 years from now. So it's really telling me that we just have to stay nimble and flexible and be prepared. The one thought I do generally have is that there is a general shift towards value-based care. So healthcare organizations need to be able to respond to that shift. I believe that is coming down the pike, and in many respects is already here.
Yeah, and I would agree with that. I think kind of goes back to our first discussion, which is that political and economic change is just kind of a reality, and the ability to adjust to it as it happens is just something that we live with, and changes in reimbursement in all jurisdictions is also something we have to live with kind of constantly. So, and the pace of how something's going to change is also so unpredictable that at this point we're still just kind of navigating the 2019 risks, I think. So certainly watching, but I think it's true. We've got enough to deal with right now.
Great, and we'll have a bunch of coverage a little later on in the day on the election and predictions and the like. Okay, so I want to leave time for questions. So let me ask one more question to you both, and then we can turn it over to questions, which is to say, the bell is ringing, they're singing Auld Lang Syne, 2019 is coming to an end, and you're in that spirit, slightly puffed up by champagne, of bonhomie and happiness. What is your big hope or wish for a happy 2020 in health law? But then you've gone to bed that night and you wake up at 2 a.m. sweating. What are the biggest worry you have for 2020 in healthcare and health law? So the positive and the negative hopes for next year.
So, for me, the big hope would be that we actually get some real clear change and guidance in the safe harbors in the anti-kickback statute, so we can actually move value-based care forward in a way that works for everyone. What probably always, as a manufacturer, that there's probably will be health general counsel probably will always be the thing that keeps me up at night, is that someone somewhere gets it wrong and we end up with a False Claims Act case, basically. So.
I will echo that wish for some clear safe harbors to get the 50-mile-an-hour driver on the road going, at least with the flow of traffic. That would be wonderfully helpful. If I were having wishful hopes, I think I would be hoping for sometime in 2020. Although it's kind of I'm not sure that it will come to fruition. Changes in the immigration related policies that have been implemented over the course of the past several years. We're in the business of providing access to health care, and these are policies that are effectively closing access to health care. You can't keep people healthy if they can't get in to see healthcare providers. So that is priority number one. The thing that will probably wake me up and keep me sweating is I'm really concerned about changes in Medicaid and how Medicaid funding for states and potentially for Medicaid waivers could be changed. Will that undercut some of the key financial bases on which many safety net providers rely?
Great. Well, we're now ready for audience questions. Just a reminder, they should be questions. They should be brief and to the point. For the first 25 words, there's no question mark there. I'll say, where's the question? Please.
Okay, 2 questions. First of all, you were talking about privacy and sharing medical data. Some of these healthcare places are sending out things like, well, if you want to be our patient, you have to agree to share data. Is that acceptable? I mean, is there informed consent there? And my second question in regard to the election, do you think these candidates are really talking about what they think they can accomplish? I mean, you hear Bloomberg talking about, health, everyone gets health care, and if you like it, you can keep it, and if you don't, you can change. Are they just giving pipe dreams to get votes, or do they really think they can accomplish this?
Thank you.
Thank you. I'm not really much of a political wonk, so on that second question, I'm not sure that I'm qualified to be able to answer it other than through my own ignorant personal point of view. I think on your first question, I know one of our key principles is to ensure the privacy of patient information, and in no circumstance do we want to put patients in a position where we're going to effectively coerce them to release their private information. That's my own view of how it should work.
Great.
Han?
Well, we have time. We'll have a follow-up afterwards. Let's get through these 2. Yep, go ahead.
Hi, good morning. My name is Han Ho. I'm from Harvard Medical School, and I practice psychiatry and addiction medicine. So my question is for Andy. I think you mentioned several times mental health, substance use disorder, at the same time also providing value-based care. I guess my question is, do you think that we have an opportunity, or actually the situation is going to be worse since on mental health and also value-based care, because I get the impression that the expectation has become, and there's a trend that we need to provide more care, but also at a lower cost. So I guess I just wonder whether the mental health department of the hospital will continue to be the only department that is losing money. That is sort of like what I'm wondering, whether there's an opportunity actually, or actually it's going to make the current situation even worse.
I think it's a question. I think we have to rethink how hospitals are structured. You mentioned the psychiatry department, and we have a psychiatry department, but I think we have to look at how is it, and we have a special outpatient addiction service. I think we need to look, though, at how is it that we can provide patients with psychiatric care or substance use care across all settings. And so I think the paradigm of having a standalone psychiatry department where we put the patient on the couch and go through psychotherapy for 50 minutes with them every week may not necessarily be the paradigm that we need going forward. And we'll have to look at, are there other ways for us to bring, for example, psychiatry into the primary care clinics? So I think without a doubt, mental health services, psychiatry, counseling, that we need to provide more of that. So I think you made a great career choice.
It's the answer you were hoping to hear. If you said the other, it'd be kind of depressing. Go ahead.
Hi, I'm Carly Zubricki. I'm a fellow here at the law school, and I'm working on some privacy-related issues, so I was delighted to hear a lot of this conversation today. So my specific question is, I would be curious to hear sort of more specific examples of places where you see privacy law actually getting in the way of providers providing adequate care for patients. I see the innovation problem, I see very obviously, but I'm sort of curious about kind of putting some more meat on the bones of when you see that happening in the sort of patient care context.
So I guess, I mean, just from a personal patient, perspective, I think, so I have, my parents are both in their mid-80s and they both have various health issues, right? And so they see a number of different healthcare professionals at different facilities, and sometimes trying to get the records together in a way to get that integrated healthcare advice can be really difficult. And so I think that's one of the things that navigating, all the consents and the different systems and whether the two systems talk to each other or not, and even if they do, have you signed the right paperwork? That, from a patient perspective, is one of the things that I've just experienced. So.
And specifically within a given system or within a given organization, one of the challenges are the rules at 42 CFR Part 2, which severely constrain the ability to share information of patients who are in a defined substance use service. And there's some real question about, would there be value in, say, that patient's primary care physician being able to discuss or see how the patient is progressing under that service. So if I were to pick one, it would be 42 CFR Part 2 in the context of a single integrated healthcare organization. That's our biggest hurdle.
Thank you.
Oh, this is going to be hard.
So another big story that blew up very quickly this year was the story around the regulation of vaping and of the Juul products. And so I'm not asking you guys your opinion on vaping necessarily. I'm not going to the truth of the matter at heart, to borrow a term from evidence, but I was wondering if, as you were following that story, you had any thoughts or takeaways on advising healthcare clients and devices, seeing a story that became incredibly big and really impacted that company very, very quickly.
Yeah, to be honest, it didn't strike me at the time because, of course, we all sort of think of our products probably differently, but I think that one of the things that we are trying to do more is to truly have real enterprise risk management systems in place, and part of that exercise should always be thinking about those events that could be catastrophic for a particular part of the business or a particular device where suddenly a regulation is passed and it's no longer legal to sell it. We should be thinking that way. That's a very good, your question's great, and it's something I should definitely bring back to my colleagues to be thinking that way. But it is, I think the way I would think about it is that what we are trying to do more is think about those risks that might materialize very quickly. So for instance, actually, one that did happen this year is environmental regulations in the state of Illinois have been, there's been an issue with a sterilization plant in Illinois, and just environmental regulations around sterilization generally in the US, and a huge percentage of our medical devices that are used in hospitals are sterilized at these facilities, but there are environmental questions around the process and how those regulations might shift and change, and plants getting shut down literally with 24 hours notice, and then patient access to those devices and how you navigate around that. So I think it's what happened with vaping, what's happening with sterilization facilities makes you realize that what you really have to think about is how are you thinking about those long-term risks, and do you have mitigation plans in place for it?
Let's get Andrew, I'm going to interrupt you. Let's get the last question on the table so we don't run out of time. But I'm going to also call the next panel to come up so we can do double duty while they're answering. So let's get you, go ahead.
Mark Suchman, Brown University. I have a question. It's essentially the Hamiltonian, Jeffersonian question about would you prefer to have uniform regulation versus, laboratories of democracy, different laws in different jurisdictions. My particular area is privacy, but more generally, I'm curious, your opinion, your executive client's opinion, and your physician client's opinion about whether it's advantageous to have different jurisdictions in which you can play around with different ways of doing things, or would you just like it to be simple, even if it's in some sense leveled up to the most restrictive regulation available, right?
Clarity is always good from one standpoint, but you're more of a multi-jurisdictional person.
Yeah, I mean, I was going to, until your last point, I was going to go uniform, but the leveling up is the problem, right? I mean, uniform, I completely agree. Clarity is always good, uniformity, but if the trade-off is leveling up to the highest level, then then we get back to the question of stifling innovation and what's really in the best interest of patients. So that's a tough one.
We're going to have to let that be the last word. Big round of applause for this panel.
Thank you.